Respected chairpersons and my friends, the LA imaging has shifted now to speckle tracking, and this is the LA strain, which shows you the reservoir strain, the conduit strain, and the booster strain. And so also the LA strain rate shows you the systolic strain rate, early diastolic strain rate, and the late diastolic strain rate. Now we know that the LV apex and the LA posterior wall actually do not move during the cardiac cycle. What actually moves up and down is the piston-like motion of the mitral annulus. So that is how the LA and LV function are very tightly coupled. Dr. Singh and colleagues looked at the LA strain and the LVGLS in normal persons and also patients with the diastolic dysfunction. And what they find is that as the diastolic dysfunction increases from grade 1 to grade 2 to grade 3, the LA strain gradually comes down. However, such a discrimination is not there with the fall in the LVGLS. So the LA strain appears to be a major discriminator of the higher grades of LV diastolic dysfunction. Now, Dr. Morris and colleagues looked at 517 patients with hypertension, diabetes, and CAD who are at high risk of having diastolic dysfunction, and they applied the AS's criteria to diagnose the diastolic dysfunction in 13.5% of patients. However, when they replaced the LA volume by LA volume more than 34 ml per meter square or LA strain less than 23%, they added 10% more patients with diastolic dysfunction. Moreover, what they find that those patients with LA volume less than 34 ml per meter square but LA strain less than 23%, these patients also show on follow-up higher incidence of heart failure hospitalization and raised filling pressure, suggesting that the LA strain drops much before the LA dilatation. Let us look at a case of 69-year-old lady, sedentary, significant shortness of breath, and we want to rule out the HFpEF in her case. So let us use the ES's HFA PEP score, which is a scoring system which is based on the ecomorphology of LA volume, LV mass, or the function E prime, E by E prime, TR and GLS, and also the BNP values. So we look at our patient and her LA volume is 40 ml, we get 2 score. The mass is not increased, we don't get any score. GLS is normal, we don't get any score. The E prime is 11 point, E by E prime is 11.7, we get 1 score. TR is normal, we don't get any score. A patient's BNP is 397, we get 2 scores. So adding all this together, we get a score of 4 to 5, which is an intermediate score, where the ESC guidelines advise to go for a diastolic stress test. So it can be an exercise echo where you want to show the E by E prime going above 15 with exercise and TR velocity going above 3.4 meters, or an invasive cath showing with exercise wedge pressure going above 25. Now, how easy is to do a diastolic stress test? Actually, only in 50% of the patient at peak exercise you get a TR jet, and also in 70 to 80% only you get a meaningful E by E prime signals. So it is quite difficult. So why not use LS strain instead? Our patient has a LS strain of just 15%. Now, long back, Dr. Fried and colleague has shown that as the LS strain reduces, the peak VO2 on exercise reduces almost linearly. So also as the LS strain reduces, the V by VCO2 also goes on increasing. Now, the Mayo Clinic group showed that patients with normal diastolic function or grade 1 or intermediate diastolic dysfunction, if they had a good LS strain, then they do not show increase in LV filling pressure with exercise. However, these three group of patients, if they have a lower LS strains, they show increase in the LV filling pressure with exercise. So that is how the LS strain predicts the exercise-induced LV filling pressure. So we'll do our patient's stress test and we find the peak VO2 is just 7.7, V by VCO2 is 36, and her TR velocity is 3 and her E by E prime increases to 17. So definitely she has a HEPPEP and we get a score of 7. But we had already predicted it by looking at her LS strain. Now the Mayo group showed that the HEPEP score after exercise almost inversely linearly correlated with the LS strain. So lower the LS strain you have, higher you will have a HFA-PEP score with exercise, suggesting that patient has got a high possibility of heart failure with preserved ejection fraction. So also there is a prognostic importance with the LS strain less than 31%. You have a higher chances of CV hospitalization and death. We can look at the dynamic LS strain. Let us look at this case. She's a 65-year-old lady, shortness of breath, and obviously we want to rule out an HepPep in her case. Now, this is a relay volume which is 32 ml. We just get one score here with the PEP score. The mass is 99. We don't get any score. Let us look at these two images. One is at rest and another is with a leg raise, passive leg raise. And let us look at her LS strain. Her LS strain increases from rest 18% to leg raise of 24%. So also her LS strain increases at rest, which was 1, with leg raise it goes to 1.5, suggesting that the LA is compliant and it is responding to increase in the venous return. So this lady may not have HepPep. Now long back the Japanese investigators have shown that patients with hypertension on passive leg raise show increase in the LA volume, increase in the LA reservoir strain, and increase in the LA booster strain, while those patients with HepPep do not show any increment in the LA volume or in the LA reservoir strain or with LA booster strain. Now our patient on has got an E by E prime of 12.5. We get one score there. She doesn't have TR. So we GLS is 16. We don't get any score here. The BNP is 500 and we get a score of 2. So finally we land up with a score of 4, which is again indeterminate. Now we make her exercise and we find that the ECG and is normal, peak exercise echo is normal, peak VO2 is very good, about 18, and the V by VCO2 is 28, and there are no lung comets. So she doesn't have an HepPep. Her E by E prime remains normal, it doesn't go above 15, and there is no TRZ at peak exercise. Let us look at the patient's LS strain at rest with leg raise and with peak exercise. And what we find that the LS strain has increased from 18% to 24% with leg raise and to 30% with peak exercise. So also the strain rate has gradually increased from 1 to 1.5 to 2.4 from rest to leg raise to peak exercise. Now this has been studied earlier by Dr. Sugimoto and colleague, and what they find is that from rest to exercise to recovery, in normal subjects, the LS strain keeps on increasing. So also the LS strain goes on increasing. That means becomes more negative from rest to exercise to recovery. However, in patients with HepPep and with HFrEF, there is a blunted response. There is no increase in the LS strain from rest to exercise to recovery. So also the LA dynamic strain has got a prognostic value. The event-free survival is less when the dynamic LA strain is less than 16%. So that is how the LA imaging is very useful in heart failure. Thank you.